Last time we were able to discuss the electrophysiology of the heart, and after that, we defined what arrhythmia is, and then followed by the pathophysiology of rhythmic condition, and then we established the gaps or the problems that will be addressed by these drugs. So now we will start discussing the different mechanisms of actions being held by antiarrhythmic agents. In particular, we have four major classifications of antiarrhythmic agents, and this particular classifications of mm, antiarrhythmics is based on the cardiac pharmacologist Vaughan Williams. Vaughan Williams. Again, we can classify antiarrhythmic agents based on Vaughan Williams classification. For the first class, okay, which is the class 1, are the sodium channel blockers. And then for the class 2, we have the beta blockers. And for the class 3, these are the potassium channel blockers, no? Potassium channel blockers. Okay, particularly, these are the agents that in majority has the capacity to prolong the effective refractory period or the action potential duration. Okay, and then finally, class 4 uh, are the calcium channel blockers, particularly those cardio selective na calcium channel blockers. So again, these are the four classes of antiarrhythmics based on Vaughan Williams classification. Now, for better memorization of these classes of drugs, na atay suggested way para dali lang ma-memorize, nga kanang magdugay gid siya as part sa inyong stock knowledge. Okay? Para di nyo malimtan nga basta class 1, sodium channel blockers, basta class 4, calcium channel blocker siya. For class 1, para dali lang siya madumduman, 'di ba? Sabi they are said to be sodium channel blockers. Okay, tandaan niyo lang yung value ng charge ng sodium is, 'di ba, plus 1. So 1 yung value ng charge ng sodium. So class 1, anti-arrhythmic siya. So palatandaan lang siya. Okay, for beta blockers, class 2, 'di ba? Since beta for letter B, I mean, yung letter B for beta, 'di ba siya yung second letter of the alphabet. Yung letter B sa beta, second letter of the alphabet. So siya yung second, so class 2, no? Palatandaan. So yan yung palatandaan natin for class 2. Pangalawa siya kasi yung letter B for beta, second letter sa alphabet, so beta. Sa class 3 naman, 'di ba ang ion channel na ilahang gina-block is potassium. Okay, yung potassium ion channel. Okay, so letter K naman, 'di ba ang letter K, tandaan nyo, or letter K, ka, siya yung pangatlong letra naman, pang third letter sa Filipino alphabet. 'Di ba ang Filipino alphabet is A, ba, ka. Okay? So yung K dyan, pangatlong letra naman sa Filipino alphabet. Okay? So yeah, siya yung class 3, potassium channel blockers. And then for class 4, calcium channel blockers, 'di ba ang symbol sa calcium na element is Ca. Okay, Ca ang symbol. Ang letter C, syempre, 'di ba siya yung pangatlong letter sa alphabet. Okay, pang third siya na letter sa alphabet. And then yung letter A, siya yung first letter naman sa alphabet. Therefore, 3 plus 1 equals 4. So, for class 4, antiarrhythmics, ito yung palatandaan natin. Okay, C, pang third letter, A, pang first letter, so 3 plus 1, 4. Siya yung class 4, calcium channel blockers. So, yan yung mga palatandaan. It might help you to easily memorize them. Okay, para di mo maglipog kinsa ang class 1, 2, 3, and 4. Now, ano yung mga general properties naman ng mga antiarrhythmics? Okay, for the general properties, first up, let us have the class 1. Since they are said to be sodium channel blockers in general, diba? Sodium channels blockers in general, but not all ha, not all. Though there are certain exceptions. Okay? So in general, they can inhibit, ito yung unang property niya, they can inhibit automaticity. Okay? For class 1 again, okay? In general, these agents can inhibit automaticity. Okay? Particularly both forms of automaticity. Di ba dalawa yung forms ng automaticity? We have the enhanced, okay, enhanced automaticity, at saka yung isa, triggered. Di ba? Triggered automaticity. Okay? So I have introduced already the difference between enhanced and triggered automaticity. So please scan over your notes for the differences. Basta ang point here is may involvement ang sodium ion. Okay? So may involvement ng sodium ion movement kapag may nangyayaring triggered or enhanced automaticity. Again, may involvement ng sodium ion, okay, or sodium ion movement kapag may nangyayaring automaticity, triggered man or enhanced. So yung ginagawa ng class 1 antiarrhythmics, they counteract the sodium ion movement. Okay? Now still under class 1, aside from inhibition of automaticity, they could also inhibit re-entry. Okay? Again, aside from inhibition of automaticity, they can also inhibit re-entry. And upon inhibition of re-entry process or mechanism, that could result to increase or prolong effective refractory period. Okay? So again, kapag na-inhibit yung re-entry, realization nyo dapat is na-enhance, na-prolong yung effective refractory period or yung action potential duration. Okay? Next, for class 2, general properties ng mga class 2 beta blockers, definitely they could also inhibit re-entry. Okay? Again, for class 2, they could also cause inhibition of re-entry or yung re-entrant tachycardia. That is why they could also prolong uh, the effective refractory period. Okay. Then for class 3 agents, mga potassium channel blockers, ang usual general action nila, general property is same with class 1. Okay, same with class 1 agents. Wherein na-mention kanina sa class 1 agents, they can block automaticity and also they could inhibit re-entry. Again, for class 3, the same with class 1 agents. Okay? So the same lang sila with potassium channel blockers. However, ang distinct nga sa mga potassium channel blockers, sila yung may highest ability to prolong refractoriness. Okay? Or to prolong the refractory period. Okay? Kaya nga naka-state, di ba? Naka-emphasize sa class 3, prolongation of effective refractory period. Again ha, sila yung may highest ability to prolong effective refractory period. Okay? And then finally for class 4, okay, class 4, calcium channel blockers, yung property or actions naman nila are the same with class 2. Okay, same with class 2 agents. Okay, and as mentioned earlier, sa class 2, particularly sa class 2 agents, they can also prolong um, the refractory period, but they do not alter automaticity. Okay? So again, absent sa mga CCBs ang pag-alter ng automaticity. Okay, so I repeat ha. Class 1, they inhibit automaticity and re-entry. The same with class 3. Class 2, they only inhibit re-entry. Okay, the same with calcium channel blockers, class 4. So generally, these are the actions of antiarrhythmics based on Vaughan-Williams classification. Next, for the therapeutic overview, I have already introduced this, diba, sa part 2 lecture video. So, isa-isa ho nato ni sila og discuss. And aside from the major ones, aside dito sa fourth major classification of antiarrhythmics, we will also discuss the miscellaneous. Okay? The miscellaneous agents. Okay? So take note of this, mga miscellaneous agents to sila, like adenosine, the digitalis glycosides, yung digoxin. And please add also included here, we have magnesium ions, okay? And also potassium ion. So bale, discuss na to ang actions ng mga ions na to in relation to antiarrhythmic actions. Okay? So this will serve as the general flow of the lecture on antiarrhythmic agents. Now, this particular figure summarizes the different classifications of antiarrhythmic agents. So, mauna sila atong ipang-discuss individually. Now, I told you already that we shall focus on the drugs that would counteract tachycardia. So we will no longer focus, for instance, those that target bradycardia. Okay? In the case of atropine, for instance. Okay? So, ayan. Because again, di ba, I have emphasized already na yung mga drugs natin, hindi sila effective for long-term use to counteract bradycardia. Okay? For bradycardia, hindi effective yung gamot long-term. Okay? Long-term use. Okay? So, mas magfo-focus ta sa drugs that targets tachycardia. With that, okay, let us now begin with the specific examples of antiarrhythmic agents. Okay, starting with class 1. Okay, class 1 uh, agents. Remember that class 1 drugs, again, they are the sodium channel blockers, and depending on the specific actions of these drugs, we can further classify them into three sections. Okay, so meron tayong three subclasses under class 1. We have class 1A, 1B, and 1C. Okay, so may mga distinct properties ang bawat section. Okay, na i-discuss natin later. Okay, for class 1A, specific examples are the following. We have disopyramide, Kinedine, and Procainamide. Then for class 1B, we have Lidocaine, Toxicities, Mexilatine, Phenytoin. And for class 1C, we have flecainide, propafenone, moricizin, and kinide. Okay? So in the case of antiarrhythmic agents, there are numerous, but particularly with class 1. There are numerous agents, numerous drugs, numerous examples. So in here, we also have suggested ways on how to somehow memorize these drugs. So very common mnemonics for class 1A agents, okay? Very common mnemonics ani nila wherein ginagamit pod sa mga tutorials nga mnemonics. For class 1A ang palatandaan is DQP. So imagine niyo lang na isa siyang burger, 'di ba? Double. Ibig sabihin ng DQP, double quarter pounder. Okay, double quarter pounder. So makarelate kaayo ang mga hilig mag-burger sa McDo ani, di ba? Kanang um, double quarter pounder na burger. So yung DQP that pertains to disopyramide, kinidine, and procainamide. So mura siya burger, DQP double quarter pounder. What about class 1B? Ang class 1B, ang common mnemonics diria is yung mga nilalagay natin kasama sa burger. Example, for L, that is lettuce, yung T, tomato, M, mayonnaise, P for patties or pepper. Okay? So, depende. Depende lang na kung sa nga P, patties ba or pepper. But as per my case, ang style ko para matandaan na ko ang class 1B is yung mnemonics ko naman dito is TMLP. Okay? Which means, for me lang niya siya. TMLP, too much love is painful, or too much love can be so painful. Okay? I don't know if effective ni sa inyo ha na mnemonics. So, depende lang po sa inyo ha. Okay, or you can have yung kanina, yung nilalagay sa burger, L for lettuce, T for tomatoes, and for M for mayonnaise, P for patties or pepper. Okay, next for class 1C naman, ang mnemonics natin is MFPE. Okay, again, ang mnemonics natin dito is MFPE. Okay, MFPE. So, since kanina you already have burger, di ba, yung double quarter pounder, okay, you can upgrade it into a value meal. Siyempre, pag may value meal, may kasama na yung burger. It could be fries. So, mag-request ka ngayon ng more fries, please. Okay? More fries, please. So, yan yung common palatandaan for class 1. Antiarrhythmics. But you can actually make your own mnemonics. Depende lang yan sa inyo. Okay? Next, let's move on to class 2. Okay, class 2 naman. For the remaining classes, wala na akong mnemonics dito. Okay, so for class 2, beta blockers, although here, di ba, we generally say class 2 are beta blockers, but not uh, not actually all beta blockers are members of class 2 antiarrhythmic. So you will learn later why. Bakit hindi lahat ng beta blockers pwedeng included as class 2 antiarrhythmics. And then for class 3, agents, examples are amiodarone, brittillium, Phetelide, and Sotalol. So you might wonder, bakit nandito si Sotalol? Diba? You can see here, Sotalol is part of class 3, although it is a beta blocker. Sotalol is a beta blocker. Okay? So also later, you will find out why is that so? Bakit siya parte ng class 3? Kahit beta blocker naman siya. And for class 4, the calcium channel blockers particularly, okay, the cardio selective drug, is verapamil. So under this is yung cardioselective drug that is verapamil. And again, the miscellaneous antiarrhythmic drugs, this includes adenosine, digitalis, and the ions magnesium and potassium ions. Okay. So right now, we will start discussing class 1 agents. So for the general actions muna ng class 1 antiarrhythmics, again, for the nth time, class 1 are the sodium channel blockers. And I have told you earlier that for sodium channel blockers, diba, they inhibit automaticity. Okay? They inhibit automaticity. Okay? And again, uh, they could inhibit automaticity, and via inhibiting automaticity, they could ultimately inhibit the inward conductance of potassium ions. Okay? So, ayan. Okay, recalling part 1, 'di ba? Sa part 1 of the recorded lecture, yung movement ng example, this is the cell membrane. Okay? Yung movement ng sodium ions is going inside the cell. 'Di ba? Yan yung movement, normal movement ng sodium ions. Okay? Yan yung inward, nagkakaroon ng inward conductance of sodium ions. Therefore, via blocking the sodium channel, via blocking sodium ion channels, these agents, class 1 agents, this will inhibit the entry of sodium ions. Now, if walang papasok na sodium ions as a result, less positive ngayon, di ba, yung inside ng cell, inhibiting depolarization. Di ba? Kasi nga, less positive na ngayon yung inside ng cell. Okay? So, lesser, inhibited yung depolarization. Pigil ang depolarization ng cells. Na kapag napipigilan ngayon ang depolarization or yung positive action potential ng cell or yung contraction ng cell, ano yung pwedeng mag-result kapag napipigilan ang depolarization or yung positive action potential? Ano yung pwedeng mag-result? Is it faster or slower heartbeat? Siyempre, slower ngayon yung heartbeat. Okay? So, slower heartbeat will occur. Slower heartbeat will dominate. Okay? Again, somehow, kapag na-inhibit yung depolarization, in this case, via inhibiting sodium channels, somehow, ang cardiac cells is depressed. Nagkakaroon ng depression of cardiac cells. That is why these agents are also called PVC killers. PVC, ibig sabihin ng PVC, premature ventricular contraction. Okay? And we also discussed later that sodium channel blockers, okay, generally again, because they block sodium channels, they inhibit the automaticity. Again, it causes inhibition or blockade of automaticity, both enhanced at saka yung triggered. Okay? Triggered automaticity. Ayan. Specifically, if blocked ang enhanced, kapag ang na-block ay enhanced automaticity. Question, anong phase? Anong phase ng action potential ang nata-target? Basta inhibited ang enhanced automaticity. Anong phase ng sinoatrial node action potential ang targeted ngayon? It is the phase 4. Okay, phase 4. Okay, kasi nga 'di ba, when we talk about enhanced automaticity, we are talking about the pacemaker here. 'Di ba? The pacemaker cells, the sinoatrial node. And we have discussed that Depolarization, okay, depolarization happens in phase 4 of pacemaker cells. Okay. So with blockade of sodium ion channel, natatarget ang depolarization, particularly the phase 4 depolarization in the action potential of pacemaker cells. Also, natatarget din ng mga sodium channel blockers ang triggered automaticity. And recall, kapag triggered automaticity pinag-usapan, involved naman dito ay mga latent pacemakers. 'Di ba? Yung latent pacemaker cells. Now, ano yung mga latent pacemakers? So, we have the AV node, Purkinje fibers. Or usually, yun yung mga non-pacemaker cells. 'Di ba? Yung atrioventricular node, Purkinje fibers. Remember, kapag nag-o-automaticity itong mga latent pacemakers na to, it is not normal. 'Di ba? That is not a normal case, abnormality yun. Kaya dapat pigilan yung biglaang triggered automaticity, yung biglaang upstroke, yung biglaang depolarization sa action potential ng mga latent pacemaker. Dapat pigilan yung triggered automaticity, okay, na nangyayari. And anong phase ba? Anong phase ba ng action potential ng mga latent pacemakers nangyayari ang depolarization? Anong phase number ng mga non-pacemakers may depolarization, di ba? That is, okay, phase 0. So with the use of um, sodium channel blockers, okay, kaya din niyang i-inhibit ang triggered automaticity, okay, via altering the depolarization happening in phase 0. Okay. So yan yung mga general mechanism of actions ng mga sodium channel blockers. So yan yung mga effects kapag na-block ang sodium channel. So most probably naaapektuhan, natatarget niya talaga yung depolarization na nangyayari. Okay, so ma-apply yun itong mga concepts na na-discuss sa part 1, sa part 2 lecture video. So I've said we have three sections. We have three sections under class 1, antiarrhythmics. At this juncture, we will discuss class 1A. Okay? Yung class 1A. Class 1A agents, these are so-called demoderate. Okay? Moderate sodium channel blockers. Okay? So, moderate sodium channel blockers. Okay, and these agents have the ability, particularly they have the ability to prolong, okay, the action potential duration. Okay, they have the ability to prolong the action potential duration or the ERP, no? Yung ERP. Thus, prolonging kapag na-prolong yung action potential duration, yun na nga, napoprolong din yung ERP or effective refractory period. Okay? Prolonging, therefore, the effective refractory period. Again, when we talk of class 1A, class 1A, these are the moderate sodium channel blockers. So, intermediate, kumbaga, yung action niya towards blockade of sodium channel blockers. So, that ultimately prolonging the action potential duration, which means napoprolong niya yung oras, no, consumed mula phase 0 to phase 3. Okay? So, napoprolong niya yung effective refractory period. That is why ang tendency, humahaba yung action potential. Okay? Kapag humaba yung action potential duration, that only means ang rate of contraction will be slower. Kaya magiging slower, bumabagal ngayon yung heartbeat. Kasi nga, na-prolong yung action potential. Humahaba yung oras bago matapos ang action potential. So, bumabagal ngayon yung heartbeat. Thus, again, with this effect, na slower heart rate, naka-counteract niya yung tachyarrhythmias. Di ba? Napapaslow nga niya yung heart rate, so opposite ng tachycardia. Naka-counteract niya ngayon yung tachyarrhythmias. And again, with prolonged action, potential duration, they causes prolonged effective refractory period as well. Okay? And meron din silang non-specific blocking effect or ability against potassium channels. Now, on the figure below, we can see here a cardiac action potential, di ba, of a non-pacemaker cell, both in color black, may black na action potential, then may red na action potential for non-pacemaker cell. Okay, ito yung tandaan nyo. Tandaan nyo, along the slides, along the presentations, marami kayong makikita ng ganito na klaseng action potential. May black tsaka red. Ito yung tandaan nyo. Yung kulay black dyan, walang drug. So, no drug administered. Yung black. Then, yung red line dyan, yung red na action potential, that is with, ito yung with drug. Okay? Particularly in this case, it has class 1A na drug applied or being administered. Yung class 1A, yung moderate sodium channel blockers is being administered. So makikita natin dito, kapag no drug, at the onset of phase 0, so this is phase 0, ayan, and at the end of phase 3, ito lang yung, ito yung time. Ito yung time na na-consume. Diba? Ito yung ERP. Diba? Ito yung ERP. If no drug. Okay? Without drug. Now, kapag may drug na, okay, may drug administration na, particularly with class 1A agent na notice that from depolarization phase, mula dito, depolarization phase, ayan, hanggang makarating sa phase 3, which is repolarization, mas humaba, di ba? Mas mahaba ngayon yung um, oras, di ba? Kaya nga, with the use of class 1A agents, class 1A drugs, they increase the ERP or the effective refractory period, the refractoriness. Okay? Wherein slower heartbeats occurs. Bumabagal ngayon ang tibok ng puso because of the increased effective refractory period or action potential duration. So, yan yung ginagawa in general ng mga moderate sodium channel blockers, the subclass 1A. And for the specific examples ulit, under this, we have Kinedine, Procainamide, and Disopyramide. Mnemonics natin dito is DQP, double quarter pounder. So, let us now discuss Kinedine. Okay? Si Kinedine is the first antiarrhythmic drug that is used. Siya yung first antiarrhythmic drug used. And as a sodium channel blocker, it can slow the upstroke of the action potential, yung upstroke process. Yes, it slows down. Okay? Apparently, kapag ginaslow down niya ang upstroke, tina-target niya dito yung depolarization. Di ba? Yan yung nangyayari sa depolarization, upstroke. So, it slows down the rate of depolarization. And also, these agent is used to treat both atrial and ventricular arrhythmias. And useful din siya for digitalis induced. Okay, digitalis induced arrhythmias. However, yung problem with kinidine is that it causes a variety of toxic effects. Okay, it causes a variety of toxic effects. And the most fatal one is the so-called Torsades de Pointes arrhythmia. Okay, ito yung fatal one, Torsades de Pointes arrhythmia. Ang patient kapag may Torsades de Pointes, ang makikita natin sa ECG, sa electrocardiogram niya, is nagdo-dominate ang QT interval. Nagkakaroon ng QT interval, interval prolongation. Okay? Prolongation. Or simply, there is, yung QT interval predominates. Okay? Predominates. Okay? Or nagkakaroon ng irregular QRS complex. Di ba? Included sa QT interval ang QRS. Okay? Kung saan sa QRS may nangyayaring ventricular contraction. So, irregular ngayon yung QRS complex. Again, the problem intercedes the pointes sa ECG niya. Makikita na puro QT interval ang ma-observe sa graph. Recall natin, di ba, ang QT interval ay QRS. Diba na? QRS, then T. Ay, T wave. Okay, so yan, yung QRS. So, ang ECG ng patient pag may Torsades de Pointes, somehow, it looks like this na. Okay? Something ingana. Okay? So, yan yung nangyayari kapag may Torsades de Pointes arrhythmia yung patient. Yan yung ECG. Okay? So, this signifies again QT interval predomination, which is a form of ventricular tachycardia. Di ba? Nagkakaroon ng ventricular tachycardia. Isa siyang form ng ventricular tachycardia. So, the point here is, si kinidine being an anti-arrhythmic, it can also potentially cause arrhythmia. Diba? And aside from that, kinidine also causes diarrhea, nausea, and vomiting. Okay? And as a drug, recall that kinidine is derived from a plant cinchona. Diba yung cinchona? Thus, it may cause a condition called cinchonism. Okay, cinchonism. Cinchonism that is characterized with the following clinical manifestation. Example, headache, tinnitus. Yung tinnitus, yan yung ringing sensation in the ears that you yourself can only hear. And then, dizziness as well. Okay, dizziness. Again, ang cinchonism, common clinical manifestation is headache, tinnitus, and also dizziness. Then, in rare cases, ang kinidine may also cause idiosyncratic, okay, idiosyncratic na mga responses. Okay, idiosyncratic, ibig sabihin ng idiosyncratic, genetically determined. Okay, genetically determined. Okay, na adverse effect. Okay, idiosyncratic responses, genetically determined siya na adverse effects. That is why we consider this as rare. Kasi genetically related man siya. So, rare lang siya na toxic effects. Or rare siya na desire toxicities. Okay, so example of idiosyncratic reactions are thrombocytopenia, hepatitis, angioneurotic edema, and fever. Okay? But again, rare lang naman siya nangyayari. So, na-discuss na nato earlier ang Torsades de Pointes. Ito. Okay? That is, again, a type of ventricular tachycardia wherein QT QT interval predominates in the ECG. And tingnan, di ba? Tingnan nyo, halos absent ang isoelectric line or yung ST segment. Okay, yung ST segment, yung may parang plateau, okay, in between the QRS and then the T wave. So nagdo-dominate na ngayon yung QRS complex or yung ventricular contraction, di ba? Something na. Okay. Next, another class 1A agents, we have procainamide. Ayan. Procainamide. Procainamide has a similar action with kinedine. Okay? Meron siyang similar actions with kinedine. Kasi syempre, di ba, same class nga sila. Class 1A nga sila, di ba? But yung distinct dito for procainamide is that less anticholinergic effects. Okay? Less anticholinergic effects siya than kinedine. Again, it has lesser anticholinergic agents than kinedine. However, ang procainamide, this agent is only second or third choice na anti-arrhythmics if the patient has ventricular tachycardia. So pangalawa or pangatlong choice lang siya for the treatment of ventricular tachycardia. Yung first on the list pa rin is yung lidocaine or yung amiodarone. Okay, amiodarone. Again, this agent, procainamide, is only a second or third line drug for ventricular tachycardia following only lidocaine and amiodarone. In other words, alternative lang siya in this case for ventricular tachycardia, alternative treatment. Now, bakit procainamide? Alternative lang siya. The reason is that ang procainamide is not recommended to be administered long term. Okay? Yung procainamide, not for long-term use. Okay? Long-term use. Okay? Again, ang procainamide not for long-term use kasi based on clinical studies, yung chronic or long-term na usage of procainamide is attributed or associated with the toxic effect na SLE. Okay? Diba yung SLE or the systemic lupus erythematosum? Okay? Or simply, this is lupus. Okay? That is lupus. You can search on the internet for the spelling of the meaning of SLE. Basta yan yung lupus. Okay. Now, aside from SLE, procainamide also causes the following toxic effects. So the same with kinedine, it also causes QT interval prolongation with irregular QRS, no, complexes, resulting to Torsades de Pointes. Okay. And it can also cause marked hypotension. Okay, it also causes marked hypotension. Okay, resulting to syncope. Okay, lalo na kapag ang procainamide was given intravenously, okay, that could really cause syncope or syncope. Okay, syncope or syncope. Again, particularly if the drug is given intravenously, yan yung nagkakos ng syncope. Okay, si procainamide, kapag given siya intravenously, it might cause syncope. Okay. Now, the reason why procainamide has hypotensive effects is that si procainamide is also said to be a ganglionic blocker. Ayan, again, meron siyang additional action and that is by blocking ganglionic receptors. And we suppose that drugs with this action is said to lower elevated blood pressure. Di ba when we discuss antihypertensives, may classification doon under sympathoplegics na ganglionic blockers. So somehow, meron siyang ability to lower elevated blood pressure. That's why meron talaga siyang syncope, adverse effects. Na-mention na natin kanina yung SLE, so no problem with that. And lastly, less common toxicities include nausea and diarrhea, rashes, fever, hepatitis, and this blood disorder, agranulocytosis. With agranulocytosis, this is particularly a blood disorder. Blood disorder siya wherein mababa ang levels ng granulocytes. Okay? Or deficit ang levels ng granulocytes count ng patient. So, sa atong body, natay tulo ka example ng granulocytes. Okay? Natay tulo ka example ng granulocytes. And uh, those are the basophils, eosinophils, and neutrophils. Okay? Basophils, eosinophils, and neutrophils. Okay? So, yan yung palatandaan, Ben, granulocytes in the body. Now, what are the importance of granulocytes? Ang importance ng Ben sa katawan is that very important sila sa body because they protect us from invaders. Okay? Example, microorganisms. Okay? They protect us from invaders like microorganisms. Thus, if there is deficiency in Ben, we are really susceptible to certain infections. Okay? Ayan. That's why ang patient with agranulocytosis are very much linked to increased risk of infections like bacterial infections. So, very prone siya sa infections. Pero again, rare lang naman, very rare lang naman ito na nangyayari. Very rare na toxic effect ng procainamide. Ayan. Excuse me. Next, after procainamide, we have the third example of class 1A, antiarrhythmic. We have the disopyramide. Okay? Yung disopyramide, and um, this is an effective for variety of SVTs or supraventricular arrhythmias. Okay? Very effective siya in a variety of supraventricular arrhythmias, and also it has an extended duration of action compared to other examples of class 1A agents. Okay? And take note that amongst the class 1A agents, i-compare nimo siya sa procainamide, yung yung kanina, are mas lesser. Kinidine, okay, mas lesser ang iyahang, not lesser, mas greater or mas highest ang iyahang anticholinergic adverse effects. Again ha, kung i-compare nimo ang disopyramide with the other class 1A agents like yung kinidine, tsaka yung procainamide, si disopyramide meron siyang highest anticholinergic adverse effects. Okay? So, ito yung reason why marami siyang um, atropine-like na toxicities. Okay? Atropine-like toxicities. Ayan. When we say atropine-like effects or toxicities, ibig sabihin, itong drug na to resembles adverse effects similar to that of the toxicities of atropine. That's why ang tawag sa kanya is atropine-like toxicities. Examples of atropine-like toxicities are dry mouth, dry mouth, what else? Urinary retention. Okay. Ayan. So, patient undergoing disopyramide, they may suffer or they may experience dry mouth. And then urinary retention, that's why some patients hindi sila gumagamit ng disopyramide because of urinary retention. Lalo na sa mga lalaking pasyente na may BPH, yung mga BPH patients. Diba? I have discussed already what is this condition, yung BPH, wherein, diba, sa BPH, yung nangyayari, there is enlargement of the prostate gland that results in difficulty in urination. So imagine, ang BPH patient, may difficulty na siya in urination. Okay? So in the first place, lisod na sa iyaha ang mag-urinate. Plus, nagtitake pa siya ng disopyramide. Okay? So nakakadagdag yan sa problema niya, yung disopyramide. So in this case, we suppose na mag-problema karon sa urination ang BPH patient. Kaya, contraindicated somehow ang disopyramide sa BPH patient. Okay? Another atropine-like effect is yung blurred vision, and then also constipation. Okay, constipation. Again, the following atropine-like effects are dry mouth, urinary retention, blurred vision, and constipation. And finally, still under disopyramide, pakidagdag na lang, meron siyang distinct contra-indication. Again, meron siyang distinct contra-indication. When we talk of contraindication here, these are the conditions that a patient has na nagiging rason para hindi pwedeng ibigay ang disopyramide. Okay? So take note, bawal ang disopyramide to patient with heart failure. Okay? Bawal ang disopyramide to patient with heart failure. Why? Ang disopyramide kasi generally si disopyramide, meron siyang negative inotropic effect. Again, disopyramide also causes negative inotropic effect. Naalala ba ang ibig sabihin ng inotropy? Recall that inotropy refers to the force of contraction. It refers to the strength of contraction. So imagine if disopyramide causes negative inotropy. Ibig sabihin, it weakens the contraction, in other words. Okay? If it weakens contraction, dako ang chance na mag-precipitate yan ng heart failure, ang disopyramide. Kaya bawal siya sa patient with heart failure, in which na-discuss ko naman anong problema sa heart failure. Weak din mag-contract yung heart. So, pwedeng magkaroon ng severe heart failure, congestive heart failure yung patient. Okay, upon taking disopyramide. To those patients with heart failure, so contraindicated talaga siya. Okay, so taken all together, that's for the class 1A agents: disopyramide, procainamide, and kinedine. Okay. Now let us have class 1B. Okay, class 1B agents. I have introduced earlier that class 1B, these are the weak. Okay, siya naman yung weak. Si class 1A, sila yung moderate sodium channel blockers. Now, for class 1B, as a weak sodium channel blockers, they do not prolong. Okay, they do not prolong the action potential duration, but instead, they can actually shorten the action potential duration. That is why in this slide, as you can see, upon administration of a class 1B agent, notice that the ERP, the refractory period or the action potential duration, decreases. Okay? Na-decrease or mas na-shorten as compared kanina na slide. 'Di ba? Kanina sa class 1A, na-prolong ang action potential, duration. So for class 1B, weak man sila, weak sodium channel blockers. So they somehow decreases or shorten the action potential duration. So that's the general action of subclass 1B as weak sodium channel blockers. For the specific examples, first on the list we have lidocaine. Okay, first on the list we have lidocaine. I believe somehow you are all familiar. You're all familiar already with lidocaine being a local anesthetic. Diba? Part to ng central nervous system drugs sa pharmacology 1. So as stated here, it also acts as local anesthetic. And plus, in this lesson, si lidocaine is an anti-arrhythmic. Okay, so take note na iyahang MOA as local anesthetic and as anti-arrhythmic na agent, the same. Parehas lang. Blockade of sodium channels. Okay? No, saan sila nagkaiba? Saan sila nagkaiba? As local anesthetic or and as anti-arrhythmic? Sa route of administration sila nagkaiba. Okay? So as an antiarrhythmic, take note, as an antiarrhythmic, syempre, ang lidocaine dapat makarating sa heart tissues. Okay? Kaya tandaan, as an antiarrhythmic, it is given intravenously. Okay? Intravenously. Syempre, kapag local lang, local anesthetic, ang pinanggagamitan ng lidocaine, pwedeng subcutaneous lang or topical lang. Bali, localized lang. Okay? Yung effect. Okay? Now again, lidocaine must be given intravenously if used as antiarrhythmic. Why not orally? Bakit hindi orally given? The reason why lidocaine is given intravenously is simply to bypass the yung tinatawag na extensive or liver metabolism. Okay, yung extensive first pass effect. Okay? Again, yung lidocaine is given IV para ma-bypass yung liver metabolism. Kasi nga, yung lidocaine, it undergoes extensive first pass effect. Okay? So this is an example of a drug that undergo first pass effect. Ano ba yung implication kapag ang gamot dumadaan ng liver? Ano yung implication? Kapag ang gamot undergo ng first pass effect, do you think dadami or kokonti ang bioavailability ng drug for circulation? Siyempre, kokonti, di ba? Kokonti. In fact, if lidocaine, if lidocaine is given by mouth, okay, if given siya by mouth, only 3% of the active ingredient ng lidocaine ang maa-absorb at ma-distribute. Okay? So imagine 3% lang. Sub-therapeutic lang ngayon ang lidocaine, 'di ba? Sub-therapeutic lang ngayon yung lidocaine. That's why very much recommended ang intravenous administration for lidocaine. Okay? And when lidocaine is administered intravenously, it can block the ventricular cells. Okay, that's why it is considered as the first line. So, take note ha, first line siya nga agent for digoxin-induced na ventricular tachycardia. So, please take note of this. Yung na-mention kanina, di ba? Si lidocaine pa rin, yung first line agent for digoxin-induced ventricular tachycardia. Alternative natin is yung kanina na na-introduce. Okay? Alternative lang yan sila kanina. Okay? Yung first line pa rin is si lidocaine, then followed by amiodarone. Okay? So please take note of this. So that is for the application of lidocaine. Now for the toxicities amongst the local anesthetics, ang lidocaine is the least cardiotoxic. Okay? Least cardiotoxic siya. As a local anesthetic ha, as a local anesthetic, least cardiotoxic siya. But it does not mean na perfect drug siya. Okay? Of course, may mga adverse effects siya owing to its sodium channel blocking effect. Particularly, yung mga effect like neurologic neurologic toxicities ng lidocaine. Neurologic, pag sinabing neurologic, it means toxicity affecting neurons. Okay? Yung mga nerves. Examples is paresthesias. Ang paresthesias, mauna siya ang condition kanang murag feeling nga ginatusok-tusok og dagom imuhang tudlo, okay, imong mga tudlo or imong mga daliri. Okay, then we have tremor, nausea of central origin, meaning sa utak, then lightheadedness, and then disturbances in speech, in hearing, and then convulsions. Okay, so these are the toxicities of lidocaine. Now, since lidocaine is not administered by mouth, okay, so ginawa ng mga chemists, mga scientists on drugs, gimodify nila ang structure ng lidocaine. Kasi nga, di ba, hindi pwede siya by mouth. So, gimodify nila ang structure ng lidocaine. That's why we have oral preparations. Preparations with effects na equivalent to lidocaine. Okay, and that is mexiletine in particular. Mexiletine, isa siyang oral congener of lidocaine. Okay, oral congener of lidocaine. Kaya ito yung agent given by mouth. But with regards to the effects or activity, equivalent. Equivalent lang siya as lidocaine. Okay, similar as lidocaine when it comes to its effect. Then finally, phenytoin. Phenytoin, this agent is an anticonvulsant. Okay, anticonvulsant siya. And also an antiarrhythmic agent under class 1B. Okay. Then with the effects or activity again, similar to lidocaine. Okay. So those are the examples of subclass 1B. Okay. Yung mga weak sodium channel blockers. Okay. So they can shorten the action potential duration. And then finally, we have subclass 1C. Okay? So, natapos na tayo sa class 1A, moderate. Yung class 1B, weak sodium channel blockers. So, proceed tayo ngayon sa class 1C. Okay? Generally, these are the strong naman. Strong sodium channel blockers. Okay? Strong sodium channel blockers. And as you can see on the figure, again, diba, itong solid block without. Ito yung without drug. Then, yung red line with drug. Okay, so as you observed, the difference of time of depolarization state with the drug versus without the drug, sobrang laki ng difference of time. Okay? So, with the use of drugs, tingnan, di ba? Tingnan, yung difference, nade-delay talaga ang depolarizations. Okay? Nade-delay yung depolarization phase. Okay? Imbis na fast na depolarization, shoot up agad, nade-delay niya yung depolarization phase. Okay? However, take note that some class 1C agents, some class 1C agents do not block sodium channels. Okay? Some do not block sodium channels. That's why, yung phase 3, tingnan, yung phase 3, yung repolarization phase, it remains unaffected. Di ba? Unaffected. Same lang ang repolarization with and without drug. Kaya nga kung titingnan mula phase 0 hanggang phase 3, okay, unaffected. Hindi nagbago ang refractory period. That is why no effect in the action potential duration. Okay? So again, ang main action ng mga subclass 1C, they delay. They delay the depolarization phase. Okay? Now let us now proceed to the different examples. Okay? So we have first on the list, flecainide. Ayan. First on the list is flecainide. It has both sodium and potassium channel blocking effect. But although it blocks potassium channels, insignificant. Ulit ko ha, insignificant yung alteration. Insignificant na siya. Insignificant alteration. Okay? Again, although it blocks potassium channels, insignificant yung alterations or action niya against repolarization. Okay? Ayan. That's why, going back to the slide earlier, kasi nga dahil insignificant ang kanyang ultimate effect against repolarization, unaffected ang repolarization phase. Di ba? Walang nagbago sa repolarization phase with class 1C agents. Also, ang flecainide is effective in suppressing premature ventricular contractions, and it may cause significant exacerbation of arrhythmia even at normal doses. Okay? Lalong-lalo na kapag may existing patient conditions like ventricular tachyarrhythmias, and then those that have history of myocardial infarction and ectopic ventricular contraction. Okay, so these are the properties of flecainide. Okay. Next is propafenone. Si propafenone, structurally, take note ha, structurally, um, speaking of propafenone, it resembles propranolol. Okay? Propranolol. Again, structurally speaking, si propafenone, it resembles propranolol. Okay? So in terms of structure, propafenone resembles propranolol. That's why, mechanism-wise, may konti silang similarities. Diba? May konti silang similarities. Hence, it is written in the slide that propafenone possesses weak beta blocking effect. And also, in some cases, it can block calcium channels. Okay? And the actions held by propafenone is almost similar to kinidine. Okay, kinidine. For the adverse effect, it includes metallic taste, constipation, and also it is a pro-arrhythmic drug. That's why irresponsible use of propafenone can potentially cause arrhythmia ulit. Diba? Mag-recurrence ulit ng arrhythmia. But this time of different cause, of different type of arrhythmia. And then we have moricizin. Okay. This is not phenytoin. Wala siya na-edit, no? This is not, tapos naman yung phenytoin kanina. Phenothiazine man. So, this is moricizin. Okay, moricizin. Okay. Again, we have moricizin, which is also under subclass 1C. This is a phenothiazine derivative. Okay. That is a phenothiazine derivative, but it has been withdrawn already, okay, from US markets. In other words, moricizin is no longer available in United States. Okay. So overall, these are the examples, specific examples of class 1C agents. Okay. So overall, we are done with the class 1 antiarrhythmic. So, kuan lang, mabilis ang recap. Class 1 agents, they block sodium ion channels. Okay. And we have three subclasses under class 1. 1A, moderate. 1B, weak. 1C, strong sodium channel blockers. Okay. Nagde-delay ng depolarization phase. Okay. Now, to summarize the action of class 1 antiarrhythmics, let's have this figure. Suppose that the black, again, yung ulit ha, yung black na solid line dyan, yung black na solid line dyan, without drug administration, yung black. Then kapag 1A, naka-label naman po, yung 1A, red, yan yung red line, 1B, yan yung blue line, then for 1C, agents, yung kulay green. So, naka-label naman. So, makikita nyo for 1A, tingnan, yung 1A ha, kulay red. Tingnan yung kulay red na action potential. Yung from phase 0 hanggang sa phase 3. Ayan, so nandiri yung phase 3. Ayan. Mas humaba ang time. Diba? Mas humaba ang time. Therefore, it only tells that there is prolongation of the action potential duration. Diba? Na-prolonged ang action potential duration. That's why nakasulat dito, effective refractory period increases. Tumaas ang refractory period. Okay, with the use of class 1A agents. Now, for class 1B naman, recall na ang class 1B agents, they are said to be weak. So, tandaan lang, weak sodium channel blockers. If weaker yung sodium channel blockade, it only means na kukonti lang. Diba? Kukonti lang yung difference ng depolarization time between node drug. Okay? Between node drug versus 1B agents. Konti lang yung difference ng depolarization time between this node drug. So, kulay blue. Tingnan yung kulay blue. Diba? Konti lang yung difference ng depolarization time. Okay? Ayan. And then, or you can have this. Okay? Ayan. So, konti lang yung difference ng depolarization time. Ang nangyayari sa action potential duration na shorten. Kasi nga, weak siya. Weak na sodium channel blockade. So, naso-shorten niya yung action potential duration or the effective refractory period. And then finally, kapag class 1C, they have strong, diba? Strong sodium channel blockade. Therefore, if may strong blockade of sodium channel, we would expect na ang inclination, yung pahalang ng depolarization ngayon, mas naka-inclined. Okay, tingnan yung kulay green. Diba? Mas naka-inclined yung depolarization ngayon. Okay? Tingnan yung graph na kulay green sa may depolarization phase, naka-inclined. Kasi nga, indication kapag mas slant, mas inclined ang line ng depolarization, ibig sabihin, mas matagal ang na-consume na oras. Okay? Compared sa without drug. Diba? Na-delay niya yung depolarization. And take note, insignificant ang potassium channel blockade effect ng mga class 1C agents, kaya unaffected ang repolarization phase. Diba? Tingnan yung repolarization phase, unaffected. Okay? Kaya ang ultimate effect sa refractory period, unaffected. Okay? Unaffected. It remains the same compared to without drug or simply no effect on the effective refractory period or on the action potential duration. Okay? So these are the sodium channel blockers. Okay? So we are done with sodium channel blockers class 1. Now let us proceed to class 2 antiarrhythmic agents. Recall that Class 2 agents are beta blockers. Okay? Sila ay mga beta blockers. And as mentioned in the previous slides, okay, yung sa introduction natin, beta blockers targets re-entry. They target re-entry. And I have discussed already the concept of re-entry wherein kapag, di ba, may re-entry, may re-entrant circuit. Ito yung process na naga-retrograde ang impulse causing extra beating. So, meron tayong dalawang actions held by beta blockers. Okay? So, to be classified as class 2 antiarrhythmics, dapat una, meron siyang, yes, blockade, ability to block beta adrenergic receptors. Recall, kapag na-block, ang beta receptors, most probably, meron siyang effect sa heart. Diba? Meron siyang effect sa heart. Kasi nga, ang beta activation being a sympathetic response, it can affect heart rate. Kaya, by using beta blockers, they can cause negative chrono, di ba? Negative chronotropy, negative dromotropy. Okay? And aside from that, another major action of beta blockers to be considered as class 2 antiarrhythmics, they should have direct membrane stabilizing effects related to sodium channel blockade. So, meron silang membrane stabilizing action. Now, by using, by having this property of beta blocker, we tend to conclude that not all beta blocker must be included in this classification of antiarrhythmics. Kasi nga, hindi lahat ng beta blockers meron ng number 2 na action. Di ba? Hindi lahat ng beta blocker may membrane stabilizing action. Okay? So, selected beta blockers lang ang included in class 2 anti-arrhythmic. So, for example, kasali na dito yung propranolol. Okay, kasali na dyan si propranolol. So, propranolol, this is the prototype beta blocker. Siya yung prototype na beta blocker that possesses membrane stabilizing effects, and it can block arrhythmias caused by exercise, okay, and also apprehension. Okay, meaning kapag galit ka, apprehend, diba? Kapag galit ka. So arrhythmia triggered by apprehension, kapag galit ka, mapapakalma ka ng propranolol. Okay? Now aside from propranolol, we also have other anti-arrhythmics na class 2. Okay, we also have other beta blockers na merong similar actions, which is having membrane stabilizing action. So other examples are metoprolol, nadolol, acebutolol, pindolol, timolol, and atenolol. Okay, and distinct to other examples is si esmolol. Si esmolol kasi, isa siyang beta blocker with the shortest half-life. Meron siyang shortest half-life. In fact, 10 minutes lang. Okay, 10 minutes lang yung half-life niya. Okay, kaya very short lang ang action ng esmolol. Short-acting lang siya. Okay, another thing to note here is with regards also, aside from this drugs, please take note also with regards to sotalol. Okay? With regards to sotalol, to a beta blocker, sotalol, although you are all familiar with sotalol as a beta blocker, please take note, as an antiarrhythmic drug, this is not a class 2 agent. Rather, this is a class 3. Okay, anti-arrhythmic. I repeat, although beta blocker siya, that is true, beta blocker siya, but it is not class 2 antiarrhythmic. Instead, this is class 3 agent. Now, bakit hindi siya class 2? Okay, bakit hindi siya class 2 agent? Number one reason, sotalol as an antiarrhythmic, it is being formulated as a racemic mixture. Okay, racemic mixture. Again ha, si sotalol, it is being formulated as a racemic mixture. Kapag sinabi nating racemic mixture, ibig sabihin yan, ang drug, ang gamot, may dalawang klaseng isomers. Okay, meron siyang dalawang klaseng isomers na equal in terms of quantity. Yan yung ibig sabihin ng racemic mixture. Yung drug or yung gamot, meron siyang dalawang klaseng isomers na equal in quantity. Okay, in terms of quantity. Okay, equal isomers. And those are 50% is made up of the L isomer, okay, the L isomer, and then the remaining 50% is made up of the dextro, excuse me, dextro isomer. So meron siyang equal dextro and levo, excuse me, isomer. Again, ang tawag ulit nito ay racemic mixture. So yan yung distinct kay sotalol. Ano ba yung relevance sa pagiging class 3 agent niya having this racemic mixture? Okay, take note, kapag ang isang beta blocker, ay may D, okay, may D isomer, it can actually prolong. Okay, it can actually prolong the action potential duration. Okay? Kapag D isomer ang isang beta blocker, whereas itong pagiging L isomer niya, that carries the beta blockade property. Okay? That carries the beta blockade property. It has something to do with the SAR, yung structure activity relationship sa PChem2. So ayan. Okay? So kaya classified as class 3 antiarrhythmics ang sotalol because it can prolong action potential duration. Di ba? Ang mga potassium channel blockers, class 3, they prolong refractory period. They prolong the ERP. Okay? Whereas the rest of the beta blockers, wala silang dextro isomer. Usually, basta beta blocker, usually not all, but usually L isomer kasi ang mga beta blockers. And as I've said, kapag L isomer, di ba, ito yung responsible for the beta blockade property. So ito yung distinct about sotalol. Hindi siya class 2 agent, but class 3 agent. Although, beta blocker siya. Okay? So, that's all for class 2 antiarrhythmics, beta blockers. Let us now proceed to class 3. Ayan. So, class 3 antiarrhythmics. Again, class 3 agents or the potassium channel blockers. Take note ulit, majority ng ions. Majority ng ions involved or gumagalaw kapag repolarization. Okay, kapag repolarization or potassium ions. Okay? Kapag depolarization, more on sodium ions. Therefore, by targeting potassium channels, very much affected ang repolarization phase. Okay, very much affected yung repolarization phase. That's why kapag gumamit ng potassium channel blockers, refer on the figure on the left side, kapag gumamit ka ng potassium channel blockers, unaffected itong depolarization phase. Unaffected. Kasi nga, usually sa depolarization phase, yung gumagalaw dito is not potassium but sodium ion. So more on sodium ion channels ang involved ba sa depolarization. That's why here, unaffected ang depolarization phase. So bale, nagkakaroon lang kapag potassium channel blockers, nagkakaroon lang ng distinct action sa phase 3. Okay, sa repolarization phase. So, ang tendency na e-extend. Okay? Na e-extend or nade-delay ang repolarization. Okay? Na e-extend ng phase 3, nade-delay ang repolarization. That's why, as a result, there is prolongation of effective refractory period or yung action potential duration. Okay. So as you can see on the figure on the right side naman, on the right side, makikita na na prolonged. 'Di ba? Tingnan. 'Di ba na prolonged ang action potential duration. So that's the action held by potassium channel blockers. Sila yung may highest ability to prolong the effective refractory period. Okay? So for the examples, ayan, we have amiodarone, Phetelide, Brittillium, the Phetelide. And yung na-mention kanina, yung Sotalol. Di ba? Yung Sotalol, class 3 agent din siya. For the mechanism of action, syempre, ang bottom line talaga, meron silang potassium channel blockade effect. Although, meron silang ito mga additional action. Let's say, for example, si Butylide. Si Butylide, it also slows down inward movement of sodium ions. Okay, again, additional action niya yan. Na nabablock din niya yung sodium ion channels. For Brittillium naman, additional action niya is that it inhibits the exocytosis. Right? It inhibits the exocytosis of norepinephrine. Again, in the case of Brittillium, it inhibits exocytosis of norepinephrine. And we have discussed already comprehensively, di ba, sa mga previous mechanism of action ng mga other drugs. Ano yung implication kapag inhibited ang exocytosis. And then we have the Phetelide. Sa the Phetelide, no other effects. No other effects aside from potassium channel blockade. Okay? So in class 3, antiarrhythmics, ang flag bearer or yung first drug on the list is si amiodarone. Okay, ayan. Okay, and particularly it has a weak adrenergic and calcium channel blocking effect. Okay, weak iyahang meta blocking and calcium channel blocking effect. Thus, it can slow down the heart rate. Okay? Meron siyang ability to slow down the heart rate and the atrioventricular nodal conduction. Also, it has high efficacy and low incidence of Torsades de Puentes. Okay? Kaya usually ang amiodarone ginagamit din siya as first line, take note, first line for ventricular tachycardia. Okay, ginagamit din siya as first line for ventricular tachycardia. Pero yung lidocaine kanina, first line siya for digitalis-induced ventricular tachycardia. Si amiodarone, this is being used as first line agent for ventricular tachycardia but not really caused by digoxin. Okay, but in general, na ventricular tachycardia. However, coupled with that advantage, si amiodarone, it has a lot of toxicities. Okay? So, maraming toxicities caused by amiodarone. Number one is directly attributable to its mechanism of action. Diba? It can cause bradycardia kasi nasuslow niya yung heart rate. So, attributable na siya nga toxicity sa iyang mechanism of action. Okay? And then heart block as well. Because again, it has the ability to block potassium, sodium, and calcium channel. Diba? And the most serious and most, let's say, most important na adverse effect, okay, most important, okay, adverse effect of amiodarone is pulmonary fibrosis, which is really fatal. This is really fatal, although this only happens sa 1% of patients. And nangyayari siya even at low dose. Okay, even at low dose ng amiodarone, nangyayari siya. Low dose administration, pwedeng mangyari yung pulmonary fibrosis. Okay, and there could also be hepatotoxic effects that would require to conduct liver function test. Okay? So, ayan, there could be hepatotoxic effect. Okay? Conduct. Okay? That would let the patient conduct liver function test. Okay, mga liver function test determination. Examples sa mga liver function test determinants are yung ALT, yung AST. Okay? And again, uh, dahil hepatotoxic ang drug na amiodarone, that could require conduction of liver function tests. Okay? Liver function test determination. Example are ALT and AST. Example yan ng mga liver function test determinant. So, that is already your part to search. Ano yung ibig sabihin ng terms na AST, ALT. Kasi more on clinical pharmacy related yan. Okay? Also, there could be photodermatitis. Okay, photodermatitis and then corneal microdeposits. And finally, hyperthyroidism. Okay, ang ibig sabihin ng hyperthyroidism, si amiodarone in general, uh, it can alter the level of thyroid hormone, okay, in the body. Bakit? Bakit meron siyang ability to alter the thyroid hormone in the body? It is because amiodarone can increase. Okay? It can increase the iodine in the body. Okay? So this effect of amiodarone is very relative to its structure. Okay, very relative yung effect na yan sa iyahang structure. Kasi 'di ba, amiodarone, amioda, ioda. Okay, yung ioda dyan. Okay, so may iodine sa structure ng amiodarone particularly. Okay? In fact, it contains 32% by weight of iodine. Okay? It contains 32% of iodine by weight. Kaya kapag may continuous use of iodine, okay, we suppose, iodine, continuous use of amiodarone, pag may continuous use of amiodarone, we can suppose na ang iodine can be accumulated inside the body. Kasi meron siyang iodine content, yung drug na yan. Diba? That's why may alteration ngayon in thyroid hormone levels. Okay? Alteration, the thyroid hormone may happen. Okay? So, kumbaga meron siyang phases or stages na nangyayari. Initially, there is hypothyroidism. Okay? However, kapag masyadong matagal na ang pag-take ng amiodarone, ultimately ang effect is hyper. Okay, hyperthyroidism. Ang tawag dyan sa condition na yan is that yung amiodarone uh, induces the condition called Wolff-Chaikoff effect. Ayan. Again, may mangyayaring iodine alteration caused by amiodarone. So, taken all together, these are the adverse effects caused by amiodarone. Next, aside from amiodarone and other mentioned examples ng class 3 agents, there are other important class 3 anti-arrhythmic. So we have dronedarone. Si dronedarone, as how the drug is named, 'di ba? As how the drug is named, dronedarone sounds like amiodarone. That is because dronedarone is structurally similar to amiodarone. Okay, but in this case, si dronedarone devoid na siya of iodine content. Devoid, that is devoid of iodine content. So kung wala siyang iodine sa structure, hindi siya associated sa mga adverse effects due to iodine like for example pulmonary fibrosis and also thyroid abnormalities or yung wolf wolf Chaikoff effect. So wala siyang ganong adverse effects. Okay? And then finally we have vernaculant. Si vernaculant isa siyang investigational drug that was developed for the treatment of atrial fibrillation. Okay? And there are certain toxicities that can be observed like dysgeusia, that is disturbance in the taste, sneezing, paresthesia, cough, and hypotension. Okay? And blank ni dere. Kung ano siya, yung na-discuss kanina, yung si Sotalol, na-discuss naman nato kanina, so okay na yun. Si Sotalol, example din siya ng class 3, antiarrhythmics. Kasi, again, it is formulated, di ba, as racemic mixture. Okay? And anong isomer ba yun ang meron sa Sotalol na wala sa ibang beta blockers? Anong isomer ba meron kay Sotalol na wala sa ibang beta blocker? Is it D isomer or L isomer? Diba? It is the D isomer. And recall, related ang D isomer ng Sotalol to its effect in prolongation of action, potential duration. So yan yung main point natin why Sotalol part siya ng class 3, not in class 2 anti-arrhythmics. Next, we also have the Phetelide. The Phetelide is used as maintenance for the normal sinus rhythm and also effective in restoring normal sinus rhythm in the heart. Okay, and Butylide naman, mainly it is used for the acute conversion of atrial flutter, which has an adverse effect of prolongation of QT interval resulting to torsades de Pointes. Okay. Next is Brittillium. Si Brittillium na introduce naman natin kanina, it is the first developed, okay? I mean, it was first developed to treat hypertension. Again, it was first developed to treat hypertension because, again, meron siyang activity to inhibit the normal physiologic release of norepinephrine, or it can block the so-called exocytosis process of norepinephrine. That is why meron siyang uh, antihypertensive activity. And because of this additional action held by Brittillium, it has found out to have a clinical benefit as an anti-arrhythmic drug. And that is by blocking potassium ion channels, which makes it part of class 3 agents. Excuse me. Overall, that is the end of class 3 anti-arrhythmics. Okay? Those that are potassium channel blockers, may highest effect towards prolongation of effective refractory period. Okay, so far, na-discuss ko na yung class 1, yung sodium channel blockers, class 2, the beta blockers, class 3, potassium channel blockers. So please take note of the properties. Ano ba yung tinatarget nila? Is it automaticity, re-entry? Is it natatarget ba nila yung depolarization or repolarization? Na-delay ba nila? Na-shorten? Na-prolong? So, dila ra gyud mag-revolve ang actions ng mga anti-arrhythmics. Okay? Then finally, we have class 4. Class 4, the calcium channel blockers. Remember, when we talk of calcium channel blockers, sobra kadaming examples. Diba? But since the problem here is arrhythmia, di ba? Ang problem dire is arrhythmia, which is a cardiac problem, uh, cardiac related, di ba, ang arrhythmia. So ang mga applicable na calcium channel blockers lang diri would be those that are cardio selective na mga CCBs. Therefore, hindi kasali dito yung mga dipins, di ba? Yung mga dipins kasi yung mga dipins vaso selective yung mga yon. Therefore, ang included lang ay mga non-dihydropyridines. We have the verapamil and diltiazem. But of course, the most commonly used here is verapamil, which is very cardio-selective. Diba? Na-discuss ko na ang mechanism of action ng calcium channel blockers before sa antihypertensive. So it is already your job to scan over your notes for the MOA, for the mechanism of action. Okay, so let us now proceed immediately with the applications of CCBs as anti-arrhythmic. So ang verapamil, this is considered as the first line. Take note, first line for excuse me, chronic PSVT. Okay, first line agent, again, first line agent for chronic PSVT or PSVT, yan yung paroxysmal supraventricular tachycardia. Okay, yan yung ibig sabihin ng PSVT. First line agent for chronic paroxysmal supraventricular tachycardia. So, siya yung commonly used one. Ayan. Okay. So, first line. Okay. For chronic PSVT. Okay. This is paroxysmal supraventricular tachycardia. And for the most common extra cardiac effect, most common na siya, common extra cardiac effect, we have constipation. Okay? Constipation. So, mauni so far mga reklamo sa patient with verapamil. Okay? Kay struggle sa part ng patient kay 2 to 3 days pa ay makapagbawas ang patient. Again, that is normal, that is normal due to its constipating adverse effect. Then diltiazem naman, this is less commonly used because it does not focus only on blocking calcium channels in the heart. Meron din siyang blocking activity kasi sa blood vessels. Di ba 50-50 man iyahang effect towards blocking calcium channels. Okay? So all in all, we are done with the 4 classifications of anti-arrhythmics. Okay? Based on Vaughan-Williams classification. Okay? Now, in some references, ang tawag kay digoxin, in some references, ang tawag kay digoxin kay class 5. Okay, class 5 antiarrhythmics. But in this case, ang tawag na please i-classify siya as miscellaneous. Miscellaneous anti-arrhythmics. Okay? Pero sa some other references, class 5 siya. So either okay lang. Okay? So with digoxin's actions, both mechanical and electrophysiological, they were already discussed in the recorded lecture video. Okay, so no problem with that. Balikan lang natin briefly. With regards to the electrical, yung sa electrical na electrophysiological na effect ng digoxin, it is actually dose dependent, di ba? It is said to be dose dependent. Ibig sabihin, kapag dose dependent, magkaiba ang effect ng digoxin electrically. Okay? At low dose versus that of high dose, magkaiba. Okay? Recall na to. At low dose, ang effect ng digoxin ay negative chrono, 'di ba? Negative chronotropy. Bakit negative chronotropy? Kasi digoxin activates vagal, ayan, it activates vagal mm, activity, 'di ba? Or it enhances the vagal activity, yung vagus nerves, iyahang activate. And I have mentioned kapag sinabing vagal activity, that is related to parasympathetic effect. That is why ang effect sa heart rate is decrease. So parasympathetic, decrease, negative, chronotropy, decrease yung rate of contraction. So bradycardia. However, kapag toxic na ang concentration or ang amount ng digoxin, hindi na siya nagkakos ng bradycardia. Diba? Hindi na bradycardia, instead it causes tachycardia. Okay? It already causes tachycardia, kaya at high doses of digoxin, pwede siyang mag-cause ngayon ng ventricular tachycardia, which is really fatal. Okay? Which is really fatal. That is why, as emphasized, always na ako gina-emphasize during my lecture regarding the drugs for heart failure, ang dose ng digoxin should be strictly monitored. Okay? Kay gamay lang na changes sa dose, delikado. Okay? Fatal ang pwede mag-result. So, digoxin, again, increases vagal activity via its action in the vasomotor center, and it can enhance effective refractory period. Then for the toxicities of digoxin, kanya siya, for the toxicities of digoxin, na-discuss na rin to, diba? Wherein it can enhance automaticity. I-scan lang ninyo inyong notes regarding digitalis toxicities. It has ability to enhance automaticity at high doses. That's why we really have to monitor the amount of digoxin administered to patients. Okay? Kanya siya at high doses na siya, ha? Ayan. And then, other miscellaneous na tayo. Aside from digoxin, other miscellaneous examples are the following. We have adenosine and later yung magnesium tsaka potassium ion. So let's have adenosine. Diretso ta sa mechanism of action ng adenosine. Regarding its action, si adenosine mainly activates its receptors na adenosine 1 at saka adenosine 2. Again, adenosine, it activates its receptors, adenosine 1 and adenosine 2 receptors. Si adenosine 1 receptors, these are found in the cardiac tissues, in the cardiac cells, cardiac myocytes, like in the sinoatrial node or in the atrioventricular node. While ang adenosine 2 receptor, these are found in the blood vessels. Okay, these are found in the blood vessels. Okay, now let's explain molecularly. Let us explain molecularly paano ang mechanism ng action of adenosine sa blood vessels first. Okay, blood vessels first muna. Okay, adenosine, by activating adenosine 2 receptors, it can cause increase CAMP levels. It can increase CAMP levels. Okay? Bakit niya napapataas ang CAMP, ang CAMP? GS, GS-linked ang adenosine 2 receptors. Now, kapag tumaas ang CAMP levels in the smooth muscles, in the vascular smooth muscles of blood vessels, it will ultimately cause relaxation of the vascular smooth muscles. Bakit? Bakit may relaxation? Because of adenosine. Take note, with adenosine, it can cause hyperpolarization. Okay? Pag may CAMP levels, enhanced CAMP levels with the activation of adenosine 2 receptors sa vascular smooth muscle, nagkakaroon ng hyperpolarization, okay, of the vascular smooth muscles. Again, with adenosine, because of adenosine, it can cause hyperpolarization of the vascular smooth muscles. Now, based on your learning before, when there is hyperpolarization, what do you expect? Less positive or more positive ang blood vessels? Less or more positive? Less positive. Okay, less positive because ano yung nangyayari doon sa hyperpolarization? There is potassium channel opening. Okay? And what have you learned about potassium channel opening kapag nagbukasan ang mga potassium channels? There is outward or inward movement of potassium ions. There is outward movement. Naglalabasan ang mga potassium cations. Kaya, less positive ang inside ng cell, hyperpolarization. Negative yung inside ng cell, relaxed. Okay? Kaya may relaxation na effect. Aside from that, another action of adenosine also related here sa activation ng adenosine 2 receptors. Adenosine also increases, okay? Upon activation of adenosine 2 receptor, it also increases the CGMP levels, okay, in the vascular smooth muscles upon activation of adenosine 2 receptor. So somehow, may idea na kayo kapag tumaas ang level ng CGMP sa smooth muscles, di ba? Recall, CGMP causes dephosphorylation of myosin light chain phosphate. Naalala? Okay. Again, si CGMP, di ba? It causes dephosphorylation of the myosin light chain phosphate. Tanggal itong phosphate, causing relaxation din. Okay? So, yan ang effect niya sa blood vessels. Okay? Kapag na-activate ang adenosine 2 receptors. But syempre, huwag kalimutan, sa arrhythmia, ang problema hindi naman about sa blood vessels. Diba? Ang arrhythmia, isang cardiac condition. Okay? Isang cardiac condition ang arrhythmia. So, focus tayo sa action ngayon ng adenosine in the cardiac myocytes. So, now, ang adenosine as an antiarrhythmic agent, it activates the receptor adenosine 1. Take note, ang adenosine 1 receptor ay isang GI. Isa siyang GI-linked receptor. Recall, kapag GI-linked ang receptor, taas or baba ang CAMP levels. Okay. Baba ang CAMP levels. Now, ano ba yung effect ng CAMP? Balikan muna natin. Ano ba yung effect ng CAMP dito sa cardiac tissues? Okay? Kapag may CAMP, okay, sa cardiac tissues, okay, recall, okay, ang tendency 'di ba? Kapag may CAMP levels inside the cardiac cell, na-activate yung tinatawag natin na protein kinase A enzyme. Okay, na-enhance, na-activate ang enzyme na protein kinase A enzyme. And kapag may protein kinase A enzyme, it causes L-type calcium channel opening, 'di ba? May L-type calcium channel opening. Okay? Ito lang i-recall ha. Ito yung nangyayari kapag may enough CAMP level sa cardiac. Okay, sa cardiac. We're talking about the cardiac cell. Okay? Na a-activate yung pKa, when with pKa, na-open yung L-type calcium channel. Okay, naalala ba yung L-type calcium channel? 'Di ba dito dumadaan ang tinatawag natin na trigger calcium. And recall kapag may nakapasok na trigger calcium, ultimately ang result sa puso ay contraction. 'Di ba? Pag may calcium contraction agad. So yan yung importance ng CAMP. Yan yung importance ng CAMP level sa puso. Now, balik tayo kay adenosine. Balik tayo kay adenosine. Si adenosine, pinapababa niya yung CAMP levels inside the cardiac cell. Kaya we suppose na kokonti lang ang L-type calcium channel na ah, open ngayon. Di ba? Kukonti lang yung L-type calcium channel na open ngayon. Therefore, kapag kukonti lang ang bukas na L-type calcium channel, lesser lang ang papasok na trigger calcium. Thus, walang magsisilabasan na calcium from the sarcoplasmic reticulum. End result, babagal ngayon ang contraction ng puso. 'Di ba? Babagal ngayon yung contraction ng puso, kaya lesser chronotropy, and ultimately that will also result to lesser dromotropy. Okay? So these are the mechanism of action ng adenosine. Okay? So for the preceding slide, ano siya? Ito, ito yung na-discuss na natin. Okay? So for example, as stated, sabi dito, sa vascular smooth muscles, si adenosine, it binds to uh, adenosine 2 receptors. Okay, i-recall kanina, ano sabi natin kapag nag-bind siya sa adenosine 2 receptors, there is opening, di ba, of potassium ion channel causing hyperpolarization resulting to relaxation. Diba? And yung effect din upon activation of adenosine 2, isang effect din niya is inhibition of myosin light chain kinase. Thus, less phosphorylation, okay? Less for phosphorylation, thus relaxation din yung effect. Ito din yung na-discuss natin. Okay? Na-enhance niya yung CGMP levels. CGMP na ay dephosphorylation, kaya relaxation din. May vasodilation effect. Sa vascular, yan yung sa vascular smooth muscle kapag na-activate yung adenosine 2 receptor. In adenosine 1, ayan. Adenosine 1 receptor naman, when activated, okay, when activated ang adenosine 1, sabi natin GI linked ang adenosine 1 receptor. Thus, baba ang CAMP. Okay? Kapag baba ang CAMP, kumusta ang L-type calcium channel? Kumusta? Inhibited. Okay? Therefore, kapag inhibited, walang trigger calcium, lesser ngayon yung rate of contraction. That's why may nakalagay negative chronotropy, negative dromotropic effect. So, giran through lang na ako, kaya na-discuss naman nato siya sa general mechanism of action. Sa first slide, ganina, regarding adenosine. Okay. Next, for this part, dagdag lang natin, another effect of adenosine in the cardiac tissue is that it inhibits the release of norepinephrine. Okay? It inhibits the release of norepinephrine. Kaya, meron din siyang anti-sympathetic effect. Di ba? Yung mang gina-inhibit din yung exocytosis. So, walang enough nga norepinephrine, hindi activated ngayon yung sympathetic nervous system. So, anti-sympathetic effect to. Therefore, that particular anti-sympathetic effect of adenosine, it could contribute to negative chronotropy, and negative dromotropy na effect. Okay? So that is for the actions of adenosine. Okay, mechanically speaking. Then for the pharmacological applications of adenosine. Okay, for the pharmacological applications of adenosine, usually adenosine is being used for paroxysmal supraventricular tachycardia. Okay? Usually. This is being used for PSVT. In fact, siya yung first, take note, si adenosine, siya yung first line, okay, for acute. Okay? Acute na PSVT. Adenosine. Adenosine is for acute paroxysmal supraventricular tachycardia because it is administered siya. So siya yung very beneficial for acute one. Okay, for acute one. Yung prompt, okay, madalian, prompt na treatment for paroxysmal supraventricular tachycardia. Yung chronic kanina, yung sa chronic PSVT, di ba, we have verapamil. Si verapamil. So, na-discuss na tong first bullet, kanya siya, na-discuss na natin kanina sa mechanism of action, adenosine, di ba? The hyperpolarization. Okay, now with concomitant use, okay, or intake of other agents, other substances like theophylline or caffeine, si adenosine, it can reduce its efficacy. Okay, pwedeng ma-reduce yung efficacy niya knowing that these substances, theophylline and caffeine, are said to be adenosine receptor blockers. So may drug-to-drug interaction ngayon. Okay? So as much as possible, wag uminom ng kape, okay, coffee, wag kumain ng chocolate, or any these are methylxanthines kasi, okay? Methylxanthines containing na mga compound substances when under adenosine therapy. Kasi that could reduce the efficacy of adenosine. Whereas effects could be enhanced naman, pwedeng ma-enhance yung effect ng adenosine by administering dipyridamole. Dipyridamole together with adenosine. Ang dipyridamole particularly ay isang adenosine na reuptake. Isa siyang adenosine uptake inhibitor. Ibig sabihin, end result na ginagawa ng dipyridamole as adenosine uptake inhibitor na e-enhance niya yung adenosine. Okay? Na-enhance yung adenosine available for action. Sa reuptake kasi, pag sinabing uptake, okay, walang inhibition ha. Pag reuptake process or uptake process, nababalik ang adenosine sa vesicles or sa storage area niya. So, hindi siya available for action. Therefore, kung i-inhibit na to ang reuptake process, i-inhibit yung uptake process, maraming adenosine ngayon ang available for binding, for actions. Kaya, napopotentiate, okay, na greater ngayon yung activity for adenosine. So, another drug interaction din siya. Kasi potentiation yung effect niya. Okay, ni dipyridamole together with adenosine. Next, for the toxicities of adenosine, we have flushing. This occurs in 20% of the patients. So flushing or redness may occur. And then there could be shortness of breath. Okay, Okay, shortness of breath due to bronchospasm. Okay, bakit? Bakit nagkakaroon ng shortness of breath or due to bronchospasm? It is because si adenosine kasi isa siyang determinant siya of bronchial tone. In fact, it enhances the bronchial tone. Again, ang adenosine, uh, it can enhance bronchial tone. When you say enhancement of bronchial tone, that only means na nagkukos siya ng constriction of bronchioles, resulting therefore to difficulty in breathing, 'di ba? And for the remedy of this adverse effect, ang patient is given ang patient na undergoing adenosine therapy, he or she is given with a pre-treatment. Okay, she will have pre-treatment with SABAS. Okay, SABAS or ito yung short acting beta agonists. Okay? 'Di ba SABAS, these are bronchodilators. Okay, bronchodilators para somehow maiwasan yung shortness of breath. Okay, so ga-undergo sila pre-treatment, initial treatment with SABAS. Okay, prior to adenosine therapy. And then we have magnesium. Ayan. Magnesium is a natural calcium channel blocker. Okay, so natural calcium channel blocker. Therefore, as a CCB, it has a similar action with calcium channel blockers na gamot. So this is usually indicated to patients with Torsades de Puentes. Okay, usually, ang preparation ng magnesium used for Torsades de Puentes is yung Magsul. Okay, Magsul or magnesium sulfate. And then finally, we have potassium. Okay, si potassium, it has two major effects. Okay, meron siyang two major effects once administered to patient. Number one is resting potential depolarization action, and number two, membrane potential stabilizing action. Now, kapag sobrang taas or sobrang taas or sobrang baba ng potassium sa body, may certain effects ito sa katawan ng patient. Una, pag mababa yung potassium, uh, that can cause early or delayed after depolarization. Kaya kapag ang isang cardiovascular drug may hypokalemic effect, di ba? It could precipitate or give rise to cardiac condition like arrhythmia. Okay? And kapag naman hyperkalemia, it can depress the pacemaker and slows down conduction. Kaya kung may too much potassium ka in the body, ang effect nun is too much relaxation pod ng heart due to excess potassium ion. Okay? Which is delikado yung too much relaxation ng heart, di ba? Kaya nga kung naaalala nyo, ang potassium, um, part siya or component siya ng tinatawag na lethal. Kung familiar mo, lethal injection. Okay? Yung potassium chloride. Okay? Component siya ng lethal injection. Okay? Yung potassium. And that is in the form of potassium chloride. Again, lethal injection component ang potassium chloride. Although, natay mga potassium chloride na gamot. Okay? Natay mga potassium chloride na electrolyte replenisher. Natay mga medical used nga potassium chloride nowadays. Pero ang akong ginapasabot diri is yung non-medical use phase ng potassium chloride. Pwede siyang maging fatal. Pwedeng maging fatal yung potassium chloride depending on how it is being administered. Yung manner of administration sa pasyente. Especially yung potassium chloride uh, lethal siya if given IV, bolus. Okay? If given siya IV, intravenous bolus, meaning, pag sinabing IV bolus or IV push, example na kay syringe. Na kay syringe, nag-aspirate ka mula vial, and then one time inject pag-administer sa patient. Ibig sabihin, isahang bigay lang, isahang inject lang or IV push sa patient. If that is the case, if that is the manner of administration ng potassium chloride, that could really cause cardiac arrest, okay, to patient. Kasi nga, depress. Okay, masyadong na-depress yung pacemakers, puro resting membrane potential ang nangyayari or na-maintain. So, cardiac arrest would happen. Okay, so yan yung component, isa sa mga component ng lethal injection. So, that's the effects caused by potassium. Okay, so overall, that is the end of pharmacologic intervention for arrhythmia, particularly during tachycardic cases. Okay, so recap lang, mabilisang recap. We have four classes of antiarrhythmics based on Vaughan-Williams classification. We have 1, 2, 3, and 4. Then miscellaneous antiarrhythmics, yung digoxin, yung adenosine, then the magnesium and potassium ions. And finally, we are done with the pharmacology of cardiovascular drugs. Okay, so tapos na tayo sa antihypertensives, antianginols, anti-heart failure, and anti-arrhythmics.